Good day. I'm Barbara McLean. I'm a clinical nurse specialist in critical care at the Grady Health Systems in Atlanta, Georgia. I'm also a nurse practitioner in critical care, although I'm not currently practicing in that role. By some, I'm considered a hemodynamic and oxygenation specialist. And today I have the absolute pleasure of having the ability to discuss some of the new strategic methodologies that are being recommended and are certainly creating quite a stir on our electronic media and internet in terms of how we treat patients in COVID-19 units with mechanical ventilation and proning. So I'm very honored to have been asked for this because I have long been in awe and very respectful for the work of Dr. Luciano Gattinoni. And Dr. Gattinoni is partially one of my idols because, like him, I believe that most of our practice should be based on physiology and the understanding of pathophysiology in terms of designing what we should be utilizing for intervention at the bedside. So in a very recent editorial that was published, Dr. Gattinoni discussed his belief that we needed to consider two subsets of patients in COVID-19. One subset of patients who actually have a loss of compliance and will be responsive to a primary ARDSNet or Berlin protocol for resuscitation, for alveolar recruitment, and for improvement of gas exchange. So of course, as we know, that means a step up in FiO2 and then a sideways step in PEEP, again FiO2 and in PEEP, and initiation of early proning. But most of us around the country have discovered that we have some group of patients who are very responsive to this strategy, and then we have another group of patients that are not responsive to that strategy. So the work of Dr. Gattinoni and his belief system as well as his research that actually provides us with the idea that there may be two specific phenotypes that we need to consider in the COVID-19 crisis and in the evolution of acute respiratory failure in the COVID-19 patient population. So I'd like to be very clear that his physiologic work and research is profound, and those of us interested in critical care and particularly in ARDS are aware of his primary effect on what it is we do for patients today in ARDS and all of his sentinel work. But now we want to be able to understand and apply this in our clinical approach to patients. So I'd like to talk about the different patient groups that I'm seeing in my institution and what our provider teams are actually applying for these patients in order to improve possible outcome. So we think about one subset of patient that actually has large lung volumes, who actually have evidence that the lungs are compliant and that they are elastic, or at least they have some modified elasticity. And in those patients who are suffering of very severe hypoxia and hypoxemic hypoxia, those patients have been likened in similarity, not to physiology, but into presentation. Very important to understand. Been correlated to patients who are similarly presenting when they have high altitude pulmonary edema. So in that subset of patients, of course, one of our considerations will be if there is pulmonary edema and there is interstitial damage and there is loss of compliance, that first of all, we're going to limit fluid resuscitation, and we're going to apply strategies for those patients that actually are alveolar recruitment strategies, higher PEEPs, APRV, pressure control inverse ratio ventilation, high frequency oscillation, and then of course consideration of ECMO if you have that possibility and you're able to apply that early on. And in conjunction with that, we would prone position. So my institution does not have ECMO capability at this time, but we are very well versed and we have the most excellent respiratory therapy department that I've ever seen. We have such a wonderful capability to strategize for alveolar recruitment maneuvers. So we move from, in this patient population, we see the refractory to nasal cannula, even up to 7 liters. Then we move to high flow, and we go to our highest potential with high flow. And if the patient is still refractory and they are hypoxemic, they're presenting with hypoxia, and traditionally those patients often will have some heart rate variability, although some of the recent work says that they are talking about a subset of patients who do not have tachycardia. That has not been my experience. All of the patients that I've seen who are critically ill have tachycardia. But I think one of the most important concepts in evaluating these patients is to remind ourselves that as we add strategies to recruit the alveoli, we are further obstructing right ventricular ejection. So we actually put the patients into a I would call a nosocomial or iatrogenic or idiopathic right ventricular failure state. So for us, one of the things that we look at quite quickly is as we see failure to nasal cannula, failure to high flow, we move to intubation and early ventilatory strategies, most of the time starting or rapidly moving to a PEEP of 14 or above, and actually administering high dose FiO2. So skipping some of that stepwise progression that we talk about with ARDSNet or Berlin, we just start at a high PEEP and we administer a high FiO2. And in conjunction with that, we consider the probability, not just the possibility, but the probability that we will need to add some form of pulmonary vasodilation or pulmonary vasodilation with as pure an inotrope as we possibly can. So we look at Flolan, we think of nitric oxide, we think of milrinone, but of course milrinone primarily as a dilator and not necessarily as an inotrope. So we still would have to consider some very low dose inotrope if necessary. So that really fits one of the subsets that Dr. Gattinoni talks about. But the other subset of patient is that patient who really does have a primary hypoxia that is responsive to oxygen therapy. And in that category, we might move from nasal cannula, we might go to high flow, then we might consider CPAP or BiPAP, and these patients actually can respond quite beautifully to non-invasive strategies. I think one of the most essential points in evaluating the current data, and again, I'm not giving you a full evaluation, just a small one in application in the clinical situations that I've been seeing. I think it's very important for us to appreciate that we really do see two different phenotypes. One is the phenotype that actually has loss of alveolar compliance and recruitment. So they have a ventilation perfusion mismatch because they have a failure of ventilation and recruitment. What Dr. Gattinoni tells us about in the second phenotype is the problem is the loss of hypoxic vasoconstriction, so much more at a microvascular level. They have lost hypoxic vasoconstriction, and those patients have a high blood flow through their lung field. So you also have a ventilation perfusion mismatch, but here it's not from a failure necessarily of ventilation, but it's from an abundance of perfusion. So we can see that we would handle these patients quite differently. Now I'm going to share with you that currently in our primary practice, we have designated nasal cannula, non-rebreather, early intubation, recruitment, high FiO2, and proning. But now, understanding that no one is saying the ARDS protocol is not correct for some subset of patients, but the statement really being that protocols are not necessarily physiologic, and they are not necessarily designed on pathophysiology. Protocols are designed to help us capture the majority or the mean of the patients who are presenting with a problem. And in this scenario with COVID-19, the COVID-19 development into a profound hypoxemic state. I think what we take away and what we can apply in all of our clinical practices is that we don't want to apply protocols blindly and to assume that there's a failure for the patient when our protocol methodology has failed. Instead, we need to step back and say, am I using the wrong strategy in the phenotype of the patient? Am I using the wrong strategy because what I'm doing isn't working? And that, I think, is one of the most important things we can do. We all can appreciate. So I've been in practice for 45 years. So Tyrannosaurus Rex was my first pet. I've been around a long time. And I appreciate the evolution from we're going to try everything to we're going to focus on something that works well for the majority of patients. And that's what we're going to apply. That's the transition from not even having evidence, but subjective data that we were applying to our patients. And we had a lot of give and take there because we actually didn't have a particular evidence-based strategy in the beginning of critical care. But now in critical care, we have really strong evidence-based strategies that we apply almost religiously to all patients. And in general, that works. But in today's practice, we're not finding that that protocolized approach really works well for all patients. So I think what Gattinoni is saying to us, and he's saying it in a very eloquent, articulate way, and I'm saying it in a very simple way, and I hope in a simply correct way, is that we really need to try to determine what the problem of the patient is in the COVID-19 population of patients, and that the early recognition of what is occurring for the patient may prevent their evolution into the second phenotype. And Dr. Gattinoni has termed that the type H phenotype. The type H phenotype is very difficult to recruit, very difficult to improve. The type L phenotype, which is that first presentation, and may be the only presentation that patient ever has, if we're aware and if we apply therapies correctly, and those therapies would be higher volumes than we're used to giving, higher FiO2, allowing patients strategically to mobilize their volumes, and then reproducing those volumes if we are giving them therapy, that we may be able to prevent the evolution from type L to type H. Type L being that first patient who has compliant lungs and moves volumes, however, is very hypoxic. In today's practice, although in the United States, we don't in general have the capability of looking at the esophageal pressures as a reflection of our airway pressures and as a further evaluation of thoracic pressures and intrathoracic strain. What we do have the capability of looking at is dynamic compliance. And dynamic compliance is actually, of course, the pressure that is yielded when one takes a breath. That tells us a lot of information about how we should be actually considering supporting our patients. So our idea now would evolve, and I think if we embrace this, and I think most of us are ready to embrace a newer idea because we've seen so much failure in our standard methodology of ARDS protocolization for our patients. I think really appreciating and understanding that these early initiatives, and sometimes for the complete hospital stay, is that the patient does have a compliant lung, that they are able to move tidal volume, that we might need to consider larger tidal volumes for those patients rather than a rigid application of a very well-defined and excellent protocol, by the way, from the ARDSNet or from utilizing Berlin definition, appreciating that that absolutely has a place, but it has a place in the patient who has lost compliance. And so really the differentiation for us is, do you have a compliant lung or do you not? If you have a compliant lung, we may need to consider the theory that your hypoxemia is related to alterations in your blood flow dynamic, and to consider that in ways in which we're determining how we're going to strategize to better oxygenate your blood flow. And of course, at the end would always be about oxygenation of blood flow with minimal damage to the lungs. So optimization of blood flow in this environment has been very difficult because first we were treating as if patients were septic, doing aggressive fluid resuscitation. Then there's discussion about dehydrating the patients so that there isn't the exacerbation of interstitial edema that further creates problems. Trying to find equipoise, euvolemia in the situation. Enough volume to perfuse the organs, but not enough volume to cause profound pulmonary edema. So as we look at these strategies and our methodologies, it becomes not only important to diagnose where you are on the lung continuum of dysfunction in COVID-19, and there's more than one continuum. I think that's what Gattinoni is telling us. More than one point on that continuum, not straight into ARDS necessarily. And then correlating that to blood flow dynamics, which are incredibly important in this state. So anyone who's ever heard me speak or knows me knows that I want us to be able to apply things simply that we understand and not to be introducing new methodologies and new strategies at such a time of crisis when our healthcare staff is already so overburdened and are merely trying to prevent death every single day. Probably we don't have the human capacity to integrate new methodologies. So very important to remind ourselves. I think most hospitals like mine, if you get admitted to an ICU, especially if you have hypoxemia, you will receive an A line and a central line. So most particularly, I just want to remind us all that if we look at our central venous pressure, not as a volume indicator, but as a right heart compliance indicator, central venous pressure, and our systolic blood pressure as an expression of LV ejection, merely that, central venous pressure to systolic pressure. That if I give you fluid and your central venous pressure rises, but your systolic pressure does not respond, I clearly have right ventricular failure. If I give you fluid and your central venous pressure stays the same, goes up a little, even goes down a little, and your systolic pressure goes up, I've done the right thing. So I have to combine strategies of blood flow and equipoise of blood flow to my pulmonary management criteria and recognize that alveolar recruitment strategies using flow that produces pressure, that's of course what PEEP is, that's what APRV is, that's what pressure control inverse ratio is, that I always want to remind myself that in that strategic relationship, I must always consider the effect on the perfusion component of ventilation perfusion. And again, that's something that Gattinoni reminds us of, that we have to consider the ventilation perfusion ratio. And last but not least, I would like to add my own particular concern in this situation, and that is that the effervescent hyperthermia. So effervescent hyperthermia means temperature goes up, may respond for a short period of time to Tylenol or ibuprofen. Temperature is up, then it comes down, and it goes back up, and it comes down, and it goes back up. This also puts an extraordinary burden, A, on our blood flow, and B, on our myocardium, and C, on our pulmonary work, on our respiratory work. It's an incredible burden to be hyperthermic. So one of the things that I really have tried to integrate into our daily care, and I'm working on it, I'm not saying it's been 100% effective, is actually applying a simple cooling blanket. We use Blanketrol as a simple cooling. I'm not talking about therapeutic temperature management. I'm talking about simple cool. And I put that blanket on top of the patient so that the patient, especially if the patient is awake, they can move the blanket off themselves if they feel they've gotten too cool. I can tell you that to a 1, when I have used a cooling blanket strategy, I actually do see that the heart rate comes down, and typically that if the patient is presenting with tachycardia and with tachypnea, that utilizing that cooling blanket actually improves the data that I'm monitoring. It will be a long time before we know whether or not anything we do has actually improved outcomes, whether or not we know strategically that anything that we're doing is actually going to create the abundance of data that we want to see, which is what we've done has improved survival with reduced morbidity, and to be able to compare that to the very significant frequency of death in patients who have been intubated in our ICU. And that moral challenge, that ethical challenge, is also balanced with the intellectual challenge of understanding physiology and applying protocols in an appropriate manner in a physiologic state, in a pathophysiologic state, and also accepting that sometimes what we've done, no matter what we've done, we cannot overcome this enemy. This enemy is a dark, dangerous one, and it keeps changing, and we have to keep changing, and we can't stay static with a protocol. I think that's really the message from Dr. Gantanoni. Thank you so very much, and I'm so honored to have been here today. Thank you.